Good afternoon, everyone. Thank you so much for joining us. Just gonna let the last few people join in here. Now that we've opened the virtual doors, people are making their way in. While we're waiting to get started, we'll just kind of go over a couple of housekeeping items to begin with. First, welcome and thank you for joining us. This is our final episode in our series on evidence-based palliative symptom assessment and management. So we're very excited for the wrap up of this series and then the beginning of our next series, which will begin in a couple months. And that has been posted on our website. So if you haven't seen that notice, please feel free to check it out at nsmhpcn.ca/echo, and you'll be able to see the upcoming dates and get registered for everything. As a reminder, there are limited seats available, so be sure to get yourself registered as soon as possible. And we do send out reminders about the sessions coming up, so you don't have to worry about that. Also, feel free to utilize the chat today. We will be asking for you to put in your name, your designation, as well as where you're joining us from, because it's always nice for our presenters to see who it is that they're talking to today. So if you could go ahead and open up the chat box and get talking amongst yourselves and introduce yourselves. It's always nice to meet people from across the country. Let's give it another minute here. All right. I'm seeing some familiar names and a couple of new ones, so welcome. Thank you so much. And while you guys are doing that, I think it's one or two, so we will be mindful of everyone's time today. Again, today we are on our last session of our evidence-based palliative symptom assessment and management, and we're discussing fatigue. Before we begin, I'd like to go ahead and do our land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewa, Beausoleil, Rama, and Georgina Island First Nations, and most recently, the Mississaugas of the Credit River First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in a spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of the broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. The Palliative Care Echo Project. I'm sure most of you are already well aware, and that's why you're here today. The Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare providers across Canada who care for patients with a life-limiting illness. And we'd like to send a special thank you to Health Canada for their financial contributions to make this special project possible today. And now some introductions. For those of you who are new here, my name's Amanda Tavalda. I'm Communications, Fundraising, and Community Specialist with Hospice Aurelia. And today I will be acting as the host and moderator. I'll keep an eye on the chat for any questions that may come up. And our presenters today are Inga and Sue, both hospice palliative care nurse consultants with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
Thank you, Amanda. So I'm Sue Martin, and I just want to welcome everybody. Inga and I are very happy that you've joined us today. Here are our learning objectives for the day. We hope that by the end of the session, you will be able to carry out conversations surrounding goals of care around fatigue, understand the importance of routine screening for fatigue, outline and identify gold standard assessment tools for fatigue, identify possible causes of fatigue, and discuss potential treatments for fatigue. So here are a couple of definitions of fatigue for you to read over, but fatigue is a subjective perception or experience related to disease, emotional state, and/or treatment. Fatigue is a multidimensional symptom involving physical, emotional, social, and spiritual well-being and affecting quality of life. It has many contributory causes, although the exact etiology is very poorly understood. Patients may use many terms to describe their experience of fatigue. Fatigue is a common symptom in progressive chronic disease. The severity and impact of fatigue may change in the course of the disease trajectory. It is frequently regarded by patients as more distressing than pain, and it is often under-recognized by professionals. Fatigue may be unrelated to the person's level of activity and not fully alleviated by rest or sleep. It is multidimensional, affecting physical function, cognitive ability, social, emotional, and spiritual well-being. Reduced physical function limits participation in preferred activities and activities of daily living. Cognitive involvement limits activities such as reading, driving, and social interactions. Fatigue can influence the patient's decision-making about future treatment and may lead to refusal of a potentially beneficial treatment. It is important to recognize that towards the end of life, there will be a point when intervention is no longer appropriate and may be distressing. At this stage, fatigue may provide protection and shielding from suffering for the patient. There are many causes of fatigue. Sometimes the exact cause can be difficult to pinpoint. Factors contributing to someone's experience of fatigue include illnesses, including cancer, heart and lung disease, kidney failure, hypothyroidism, and neurodegenerative illnesses such as motor neuron disease or metabolic conditions. Other factors can be treatments, especially radiotherapy and chemotherapy, medicines such as opioids and antihistamines, anemia with a low blood count, sleep disturbance, depression, illness-related weight loss or cachexia, poor nutrition, and environmental factors. Having lots of visitors, for example, can definitely lead to fatigue. Fatigue is one of the most common symptoms encountered by palliative care patients, affecting greater than 80% of patients, and the most associated with moderate to severe distress. In a previous study on fatigue in patients admitted to palliative care, it was shown that fatigue increased closer to death. However, fatigue was more distressing and associated with impaired quality of life in patients with 2 to 6 months left in life, while the association between fatigue and quality of life disappeared during the last few days and weeks of life. Fatigue is expected in disease progression. We know that, and is part of the normal clinical changes that occur approaching the end of life. Fatigue could have a negative impact on the patient's physical, psychological, social, and existential well-being with impaired quality of life. This can lead to economic consequences and significant distress for both the patient and the family. Malignant and non-malignant diagnoses are equally affected, and the neurological cohort shows the greatest variability. The degree of distress correlated with the patient's functional level. It worsened as the patient's function declined and the person became bedbound when the reporting of distress reduced. So under symptoms, fatigue is a feeling of tiredness or lack of energy. It is the most common symptom for people with cancer. Fatigue is different for each person. Chronic cancer-related fatigue may not get better with rest. It can affect your ability to function. It may affect you physically, emotionally, socially, and spiritually. Signs of fatigue include feeling weary or exhausted. Your body, especially your arms and legs, feel heavy. You do not feel like doing normal activities like eating or shopping. You find it hard to concentrate or think clearly. So mild fatigue would be reflected on the ESAS 1 to 3, and the person would have minimal fatigue symptoms, be able to carry out activities of daily living, including self-care, homemaking, work, and leisure. Moderate fatigue on the ESAS is rated 4 to 6. Symptoms are present and cause moderate to high levels of distress. There would be a decrease in daily physical activities with some impairment in physical functioning. Severe fatigue is reflected on the ESAS 7 to 10 is significant fatigue on a daily basis, excessive need to sit or sleep, severe impairment of ADLs, sudden onset of fatigue and or shortness of breath at rest, a rapid heartbeat, and or blood loss. This is taken from the Cancer Care Ontario guidelines.
So goals of care conversations. Determine goals of care in conversations with your patient, family, and interdisciplinary team. Goals of care may change over time and need to be reconsidered at times of transition, like with disease progression or transfer to another care facility. This is a graph about advanced care planning and goals of care. So advanced care planning is related to future care. It includes determining who the SDM or the POA is or are, and determining wishes, what is important for the person. This then will help us to determine what the goals of care are. This will require frequent conversation. These conversations then lead to decision-making, like talking about resuscitation, etc. Goals of care and decision-making conversations are current care discussions, which will require frequent revisiting. So we're going to have a look at screening and assessment. So given the reluctance of patients to admit fatigue and that healthcare providers often miss fatigue as a symptom, it is vital to screen everyone for fatigue. All palliative care patients should be screened for fatigue and explore the person's experience and understanding of fatigue. Acknowledge and validate the reality and significance of the symptoms. Be aware that patients may have multiple comorbidities impacting fatigue, for example, cardiac or respiratory disease, renal or hepatic impairment, malignancy, hypothyroidism, hypogonadism, adrenal insufficiency, and neurological conditions. Under assessment, we need to consider symptom patterns and duration. We need to look at severity. Is it mild, moderate, severe? We can use the patient-rated assessment 0 to 10 scale. Impacts on function and quality of life. For example, everyday activities can seem impossible. Impact on family and care providers and contributing factors. Components of a comprehensive symptom assessment. So gather information from the person, family, and the interdisciplinary team. Complete a physical exam. So you use your eyes, your ears, your nose, and your touch. Consider other sources of information, such as imaging, lab tests, and other diagnostic tests. And under diagnostic tests could be CBC, including sodium, potassium, calcium, magnesium, renal function, glucose, C-reactive protein, albumin, urine analysis, and probably many more.
So gold standard assessment tools is the next piece. Next slide. Yeah, we're going to share some gold standard assessment tools with you. We're not going to go into great detail on the tools. This is really to inform your practice and increase awareness of available tools utilized for assessment of fatigue. So this is a list of the tools. Next slide. The brief fatigue inventory. So the BFI is used to rapidly assess the severity and impact of cancer-related fatigue on daily functioning. It's a self-reporting tool and it takes about 5 minutes to complete. The Edmonton Symptom Assessment System. So the ESAS-R is a self-reporting tool. The time frame for symptom ratings is specified as in the moment. Symptoms are rated on a scale of 0 to 10, 0 reflecting no concerns, 10 the worst possible. There are brief definitions for each symptom. Tiredness is lack of energy. Drowsiness is feeling sleepy. Depression is feeling sad. Anxiety is feeling nervous. And well-being is how you feel overall. Appetite reflects lack of appetite. And related symptoms such as tiredness and drowsiness, nausea and appetite, depression and anxiety are grouped together. And well-being is now the 9th symptom at the end of the instrument. The example of constipation has been added to the 10th scale or as other symptom. the ECOG performance status scale. It was developed by the Eastern Cooperative Oncology Group, ECOG, now the ECOG Akron Cancer Research Group, and it was published in 1928. So 1982, that would have been a long time. It was published in 1982. The ECOG describes a patient's level of functioning in terms of their ability to care for themselves, daily activity, and physical abilities, such as walking and working. It determines the ability of patient to tolerate therapies in serious illness, specifically for chemotherapy. This is used to assess how a patient's disease is progressing, assess how the disease affects the daily living abilities of the patient, and determine appropriate treatment and prognosis. And the next one is the FACIT-F, so Functional Assessment of Chronic Illness Therapy Fatigue Scale. So this is a 13-item measure that assesses self-reported fatigue and its impact upon daily activities and function. It was developed in the mid-1990s to meet a growing demand for more precise evaluation of fatigue associated with anemia in cancer patients. It has been utilized in research for those with cancer as well as many chronic illnesses. In all cases, the FACIT fatigue scale has been found to be reliable and valuable. The PPS, the Palliative Performance Scale, is a reliable and validated tool for assessing a patient's functional performance. It's utilized across all healthcare sectors. There are 5 categories which are measured in 10% decremental stages, and it's divided into 3 phases. Stable phase is 70 to 100%, transitional is 40 to 60%, and the end of life phase is 0 to 30%. And now we have the Cancer Care Ontario algorithm for cancer-related fatigue. It's made up of 2 pages, so we refer to page 1 or page 2. This guideline helps healthcare professionals assess and appropriately manage a patient's cancer-related fatigue. It's also a valuable tool for those experiencing fatigue related to chronic disease. And the link will be added into the chat box for your reference, and we'll be referring to this tool throughout the presentation. Okay, Inga.
Thank you. So we're going to go towards determining possible causes. So always balance the burden of a possible intervention against the likely benefit. Always, always. Does the intervention require transfer to another care setting or anything else? We have broken down the possible causes into 3 categories, as you can see here: general factors, condition-related factors, and treatment factors. So under general factors, we're going to look at patient and family roles and responsibilities, sleep disturbances, nutrition, diet, absorption, deconditioning due to reduced activity levels, fitness and/or muscle wasting, overexertion, psychological factors, for example, anxiety or fear, and depression. Under condition-related factors, we're going to look at metabolic abnormalities, anemia, infection, disease recurrence or progression, anorexia or cachexia, poorly controlled symptoms, for example, pain. Treatment factor could be dialysis, biologic therapy, for example, interferon, surgery, prescribed medications like beta blockers, sedating drugs, corticosteroids or opioids, over-the-counter meds, cancer treatment like radiation, chemotherapy, or hormone therapy. So let's look at the principles of management. It's person-centered approach and with an interdisciplinary team. We're going to look at reversible factors, non-pharmacological interventions, and pharmacological interventions. So as always, we utilize a person-centered approach, and the patient's potential will be maximized through a combination of person-centered approaches in partnership with the interdisciplinary team. Maximize the patient's potential. This multidisciplinary team involvement to support psychosocial, emotional, and spiritual concerns. And we have dietitians, pharmacists, OT, PT, spiritual care providers, MD, NP, PSWs, nurses, volunteers, SLP, social workers, and there's probably many more that I haven't mentioned yet. So there's a whole gamma of people that would fall into that multidisciplinary team. So treat potential reversible factors if appropriate. For example, blood transfusions may be useful in some patients. Other symptoms and comorbidities should be managed and all medications reviewed. When considering a management approach, always balance burden of a potential intervention against a likely benefit, as I said before.
With non-pharmacological interventions, we encourage the patient and family to prioritize meaningful activities and to give themselves permission to take a less active role in those day-to-day activities. For patients who are near end of life, redirect the focus from physical function to other enjoyable activities and focus on whatever quality of life means for that person. So the principles of management non-pharmacological treatments for mild fatigue would be to provide the patient and family education on methods of energy conservation and counseling to support self-management and coping. Encourage moderate physical activity to preserve muscle function. We would continue to the Cancer Care Ontario Care Pathway number 1, which includes education, counseling, and encouragements/support. We already know that the mild fatigue ESAS score is 1 to 3. Minimal fatigue symptoms include minimal interference in self-care, daily activity, work, and leisure. So we need to educate on the difference between normal and disease-related fatigue. Treatment-related fatigue patterns, fluctuations, persistence of fatigue post-treatment, factors of fatigue, consequences of fatigue. We need to educate on the benefits of physical activity and the signs and symptoms of worsening fatigue in order to report to the healthcare providers. Provide counsel around the need to balance energy conservation with activity, and encourage patients to use a treatment log or diary to monitor levels and patterns of fatigue to help ascertain peak energy periods and to help with planning activities. In moderate fatigue, symptoms are present and cause moderate to high levels of distress. There's a decrease in daily physical activities and some impairment in physical functioning. ESAS-R score 4 to 6. For the moderate and severe pathway, we should follow Cancer Care Algorithm for Fatigue, page 1, which includes reviewing the fatigue severity scores with the patient and family, completing a focused assessment of fatigue using the acronym assessment, completing a comprehensive assessment of fatigue, including lab tests and a physical exam. Non-pharmacological interventions for moderate to severe fatigue include advising the patient to engage in moderate intensity of physical activity as tolerated. Psychosocial interventions might include complementary therapy if that was helpful, a consultation or referral to OT or PT as appropriate, optimize sleep quality. Stress reduction strategies may improve fatigue with perhaps yoga or mindfulness programs. And attention restoring therapy may distract from fatigue. So reading or playing games, some music, gardening, or experiencing nature. Severe fatigue, so an ESAS score of 7 to 10. For the moderate and severe pathway, we should follow the CCO algorithm for fatigue, again on page 1, which includes reviewing fatigue severity scores with the patient and family, completing a focused assessment of fatigue using that acronym assessment, and completing a comprehensive assessment of fatigue, including a physical exam and lab tests if it's within the goals of care for that person. This is exactly the same as what you would do for the moderate pathway, except that there's a greater urgency to manage contributing factors and address safety issues such as falls. Non-pharmacological treatments include general measures, education of the patient and family, and stress management. Under general measures, think about physical activity and exercise. An appropriate level of exercise can reduce fatigue and should be recommended. So consider a physiotherapy referral to ensure exercises are tailored to individual needs, particularly for those patients who have advanced disease or experiencing effects from treatments, for example, anemia, osteoporosis, bone mets, or have had falls. Consider nutrition optimization. What does this person's diet consist of? And consider a referral for community supports as appropriate. Is there a need for a nutritional consult? or perhaps support for personal care. Under education of patients and caregivers, try to normalize the situation as able. And again, the use of a diary, an activity fatigue diary, may help to identify precipitants and timing of symptoms. Energy conservation and restoration. So consider a self-management plan to set priorities, delegate tasks, pace activities, and attend to one activity at a time. Schedule activities at times of peak energy and conserve energy for those really valued activities. Eliminate non-essential activities. Consider an occupational therapy referral for advice on minimizing energy expenditure and appropriate aids and equipment. Sleep pattern advice. For example, is the person sleeping well? Maybe they benefit from a hot drink at night or avoiding stimulants. Offer appropriate verbal and written information. Under psychosocial interventions, consider stress or anxiety management, relaxation and complementary therapy, which might include art, music, forest bathing, spiritual practices, or yoga.
So pharmacological treatments. Medical interventions, we could be using transfusions benefits for if a person is anemic. Oxygen therapy might be beneficial at times, but we don't have all of the answers in this. There might be more interventions that we are at the moment not aware of. So the evidence is still weak for using pharmacological treatments on fatigue and palliative care patients, although methylphenidate, Ritalin, and corticosteroids may be considered. According to the NCCN guidelines, which is a National Comprehensive Cancer Network, both methylphenidate and shorter courses of corticosteroids can be considered in end-of-life management of cancer-related fatigue. ESMO, which is the European Society of Medical Oncology, on the other hand, could not reach a consensus on the benefits regarding methylphenidate, but advocates shorter courses of corticosteroids in patients with metastatic cancer. No other pharmacological interventions are deemed beneficial in this setting by either ESMO or NCCN. As an invisible symptom, fatigue is often misunderstood by patients, by their families, friends, colleagues, and even healthcare professionals. Open discussion should be encouraged, not discouraged. Often patients feel guilty about not able to longer contribute fully to the family life, and this should be acknowledged. There's a resource, the Macmillan Get Active Feel Good resource, that might be helpful in this instance. Patients who are fatigued will have limited energy and may find it difficult to do some simple everyday things that are usually taken for granted. The basis of managing fatigue is to ensure that the best levels of energy are available and used in the most efficient way. For many patients, fatigue will be part of their experience of living with their illness. Through awareness and acknowledgement of the symptoms, considerations of lifestyle, and the use of particular techniques, it is possible to manage fatigue and take steps to reduce the impact of it on our daily life. And then we're going to go to a case study.
Yes, I know everyone is fatigued, but it's time to wake up because we are going to present you with Judy. Judy is a 78-year-old female. Her diagnoses include a well-controlled diabetes mellitus type 1, COPD, which was diagnosed at age 72. She has hypertension, osteoarthritis in both knees, and IBS, irritable bowel syndrome, managed with her diet. She ambulates independently with a rollator walker. She's independent with personal care, but needs to pace herself. She's independent with her IADLs, but her spouse does help with the grocery shopping. Her PPS is 60%, and her ESAS fatigue score is 2 out of 10. Judy lives with her husband of 50 years and their 7-year-old dog, Maisie, which is a lab, and they live in a 2-story home. They have 2 children, both are supportive, but living out of the area. Judy was a teacher in the public school system and has been retired for 25 years. She has a very supportive community and has volunteered at the food bank for many years. She and her husband have been a member of the local United Church for many years as well. This is a list of her medications. So she has Advair inhaler daily. You can take the Ventolin inhaler as required. She's on NPH insulin and regular insulin. And she has acetaminophen 650 milligrams TID, and then Lomotil as required. Judy has shortness of breath on exertion. Her recovery time is 2 to 5 minutes after completing personal care. She reports pain, abdominal cramping intermittently, and she has aching in both knees and reports neuropathy in both of her feet. She has limited mobility due to pain from her knees and shortness of breath on exertion. She's easily fatigued and requires afternoon rest time for about an hour. She says she's sleeping well at night and feels rested in the morning. Her ESAS is as follows. Her pain is 3 out of 10. Tiredness is 2. Drowsiness is 0. Nausea is 0. Appetite is 0. Shortness of breath is 2. Depression is 0. Anxiety is 0. Well-being is 1. And constipation is 0. So what level of fatigue is Judy experiencing at this point? Please just enter that into the chat real quick.
We have mild as a response. Mild, a lot of mild fatigue.
Right, you've been listening. So remember that the general factors contributing to mild disease include the patient and family roles and responsibilities. So Judy is independent with most of the IADLs, although her spouse, as we said, helps her with groceries. Some sleep disturbances can be a general factor, but Judy's reporting that she sleeps well. Nutrition is a factor, diet and absorption. She's on a diabetic diet and she has irritable bowel syndrome. So perhaps there may be some malabsorption happening. Judy likely has some deconditioning due to reduced activity levels. And she has likely overexerted herself with relation to previous commitments to volunteer activities. Psychological factors, maybe there's a fear around aging and depression or grieving. She might be grieving the loss of her independence and endurance. So mild fatigue, we already know that the ESAS score for mild is 1 to 3, and she's by 2 out of 10 as her score. Minimal fatigue symptoms are minimal interference in self-care, daily activity, work, leisure. We need to educate with her the difference between normal and disease-related fatigue, the contributing factors of fatigue and consequences of fatigue, benefits of physical activity, signs and symptoms of worsening fatigue, and counsel regarding balance, energy conservation, and perhaps use of distractions. We can encourage her to use that treatment log or diary to monitor levels and patterns of fatigue to help ascertain those peak energy levels and to help with planning activities. So when you're using the acronym assessment, think about the T for trends and timing. Pharmacological interventions. Do you think it would be appropriate to introduce a pharmacological intervention at this point? What do you think in the chat?
We have a no.
No.
I do not think it's appropriate.
Yeah. Yeah, it wouldn't be appropriate at this point, but we should certainly look at the interdisciplinary team and consider, are there other referrals that could be added here that would support this lady, such as maybe a dietitian or nutritional referral, maybe the pharmacist to review her medications, physio or OT, or spiritual support. So we would really need to take a look at the big picture of the interdisciplinary team. All right, Inga.
So we keep on going with Judy. Judy is now reporting a significant increase in fatigue. She's got some weight loss and increased shortness of breath. She has gone to her MRP and done some investigations, which one of the investigations was a CT scan. And from the CT scan, she then was sent through for a lung biopsy. The lung biopsy came back and confirmed the diagnosis of stage 4 small cell lung CA with mets to the brain. We've asked her again to do her ESAS, and the ESAS score that she's giving us are pain 3 out of 10, tiredness now is 8, drowsiness 1, nausea 2, appetite 7, shortness of breath 6, depression 1, anxiety 4, well-being 5, and her bowel movements 3. So what level of fatigue does Judy have right now? If you can put that in the chat for us.
Severe across the board.
Severe, perfect. You guys are listening. Wonderful. So her PPS now is 50%, and her ESS score, as like I said, is 8 out of 10 for fatigue. She's receiving radiation therapy for symptom management and now requires assistance with personal care and meal prep. She's got a visiting nurse coming in twice a week, and advanced care planning has been initiated. The community support has approved PSW support, but she is waitlisted, as happens a lot nowadays. So under severe fatigue, like we see that she is severe fatigue, we want to make sure that we refer her to the multidisciplinary team and pull in all the people that we can pull in to support her and to support for comfort and safety in activities. We want to include pharmacological and non-pharmacological approaches as appropriate. We want to continue the CCO, the Cancer Care Ontario Care Pathway, number 2 and 3, which includes importance of physical activity, psychosocial interventions, consultation and referral to the multidisciplinary team, as I said, optimize sleep quality, stress reduction strategies, just to make sure that we can get everything maximized as we can. In severe fatigue, symptoms are present and cause moderate to high levels of distress. There's a decrease in daily physical activities and some impairment in physical function. So in the fatigue, the ESS score is between 7 and 10. For moderate and severe pathways, we should follow CCO algorithm for fatigue page 1, which includes completing a focused assessment of fatigue using the CCO acronym algorithm assessment tool, a comprehensive assessment of fatigue, including lab test and physical examination as appropriate. Pharmacological interventions, we might be looking at a steroid with caution and monitor her blood glucose levels because she is diabetic. Non-pharmacological interventions for moderate to severe fatigue, we want to look at energy conservations, encourage gentle range of motions like short walks as able, if it's able to do so for her. We want to look at psychosocial interventions, and again, like yoga, meditation, spiritual support from her parish, because Judy was very active in her parish. Stress reduction strategies may improve fatigue, like yoga and mindfulness programs, and those come back again and again, just very important. Attention restoring therapies may distract from fatigue, like reading, games, music, gardening, experience nature, animals. And advised Judy that there is insufficient evidence for pharmacological treatment like herbal medicines and acupuncture. Just the research is not out there. Pharmacological interventions. We want to start her on a low dose of opioid for her dyspnea. We would like to start a steroid for her brain meds and energy and to stimulate appetite. And she was started on some oxygen therapy as well. There's a great urgency to manage contributing factors and address safety issues such as falls. So now we're two months post-radiation and her health status is still declining. Her PPS now is 30%, but her ESS score has come down a little bit. From 8, she's now 6 out of 10. She's got visiting nurses 3 times a week, and the PSWs are coming twice a day. Goals of care are to remain at home with support from family as long as possible, and then go to a residential hospice for end of life. She's got a granddaughter who is expected to arrive from overseas next week with Judy's first great-grandchild. And she's worried that she will not be able to enjoy the visit due to the increasing levels of fatigue. So we ask her about her ESS scores again, and they read, pain is now 2 out of 10, tiredness 6, drowsiness 1, nausea 2, appetite 7, shortness of breath 4, depression 2, anxiety 4, well-being 5, and her bowel movements are the same at 3. So what level of fatigue is Judy experiencing now? She's a 6 out of 10.
Moderate.
Wonderful, guys. Beautiful. So moderate, which on the ESS scores would come out 4 to 6. Severe is 7 to 10. So she has moderate level fatigue because there is some improvement as she is now bedbound, and fatigue levels usually decrease at the point due to fewer demands. So Judy has now significant fatigue on a daily basis. She is bedbound. She's dependent for all care. And Judy has sudden onsets of fatigue and or shortness of breath at rest. She also has a rapid heart rate. She is now in a hospital bed located on the main floor of her two-story home. Judy did receive some Ritalin prior to her granddaughter's visit and was able to spend some quality time with family. And advanced care planning was reviewed. The SRK, the symptom relief kit, and the EAT protocol, the expected death in the home protocol strategies, were put in place. So for the moderate and severe pathways, we should follow the CCO algorithm for fatigue page 1, which includes completing the focused assessment for fatigue, again, using the CCO acronym algorithm assessment tool, a comprehensive assessment of fatigue, which might include lab tests and physical exam as per patient's goals of care. There's a great urgency to manage contributing factors like the issues of safety and falls, but in Judy's case, that might not be as much as she is now in a hospital bed. Pharmacological interventions. So she had Ritalin for visit with family. We want to continue the steroids for energy and perhaps, and an opioid for her dyspnea. The methylphenidate, the Ritalin, they're tabs. I just want to give you a little bit of background information on it. They come in 5, 10, and 20 milligrams, and normally over the age of 65, they're not recommended. From age 18 to 65, we could start with a 5 milligram BID in the morning and noon. Don't use it at night. You would keep them up. Use 2.5 milligrams for frail patients with a maximum of 15 milligrams PO BID. Methylphenidate is a short-acting stimulant with a duration of action of 1 to 4 hours and a pharmacokinetic half-life of 2 to 3 hours. Maximum drug concentration after oral administration occurs at about 2 hours. So we want to get back to the last little bit of Judy. Judy did have a good visit with her granddaughter and great-grandson. She died peacefully at her home the next day with family at her bedside. And that is the story about Judy. I want to thank you guys for joining us today. We are at the end of our presentation. If you have any questions or comments, please put them in the chat for us. And if you can see here a QR code for a satisfaction survey, if you guys want to fill that out, that would be greatly appreciated. Thank you for being here.
Thank you, Inga and Sue. That was fantastic. I really enjoyed that. And the case study was great as well. I've also put a link to the survey in the chat box as well today. So please feel free to grab that there. And as mentioned, a link to the copy of the algorithm will be sent, or is in the link in the chat box, my goodness, and will be sent out along with a copy of a link to the slides, as well as a link to the recording when we do our follow-up email. So we hope that you enjoyed today, and I'm not seeing any questions other than a question about the slides, which I just mentioned. So I think that we are all great to go. And please remember to fill out those surveys, because it is what helps us to build our upcoming series and sessions to make sure that they are what our community is looking for. Thank you all and have yourselves a great day.
Thank you.